So, hello everybody, my name is Ulf-Dietrich.
Wszystkim nazywam się Ulf-Dietrich Braumann.
I am honored to be invited with Markus Bauer together to give a presentation in this conference on a certain application of AI for histopathology. In the beginning, I will be talking a little about the disease itself, and later on I continue to give a brief introduction to convolutional neural networks, and afterwards Markus Bauer will take over and speak about his solutions on this certain topic, prostate malignancy grading in histopathology. We are both are engineers, and we are working together with bioinformaticians and clinicians as well. Next slide, please. A few words on the disease. Prostate cancer is an alteration of glands in the prostate. It's an adenocarcinoma because the epithelia of the glands are changing in different grades. And if you look onto the right side, you see the European map, and you will see at the first glance there is an east-west difference in the first prominent male malignancy. And in the Western European part, it's prostate, and in the Eastern European part, it's lung cancer for men. But believe me, it's the second most severe cancer in the Eastern European part. I mean, the prostate cancer. Looking on the left side, the two diagrams, you see prostate, the incidence is almost a quarter among the malignancies of cancer, but the mortality is not that severe. However, it is still a challenge for the clinicians to do the correct diagnostics, especially using tissue sections, and that is in one word the histology. Next slide. On the right side, you see the prostate is more or less in the center of the pelvis. And once there is suspicion that the prostate has a disease, there is a certain set of routine assessments, for example, manual digital rectal examination with the finger to detect if the prostate is enlarged. Of course,
Rektum, które pozwala nam wykryć, czy ten gruczoł się powiększa. Mamy tutaj.
And also some transrectal ultrasound can be made, and if still the suspicion is true, oh, I'm sorry, no, yeah, thank you, then an histological examination is required, and that is the decisive investigation of the clinicians, of the pathologist, to decide if a cancer is present or not. And if a cancer is histologically proven, then a certain procedure of assessment of the aggressiveness is being made. And I tell you about the Gleason score in a minute. And because at that stage, there are punch biopsies with a needle are being restricted from the prostate. It's a certain set and a certain procedure. On the lower right, you see an example of an image of a section of these needle biopsies. And this is being assessed here on the right-hand side. On the rightmost side, there's a darker part, and that is probably tumor region. And other diagnostics can be made. I skip this. Next slide. This is what a typical pathologist is getting served from the technicians. A pathologist gets 100 of such cases per day, not only prostate, of course. Here you see prostatectomy cases. This is just not a needle biopsy. For this case, the prostate has already been removed, and among here of these 57 slides, 42 slides are from prostate, the others are lymph nodes. And these have to be carefully assessed by the specialist. And if you raise the question, does medicine require AI? On that point, maybe many of you might think yes, because it's a lot of work, it's a lot of manual work, it's boring work, and there's a couple of problems I show you on the next slide. 55 years ago, there was a guy, Donald F. Gleason, and who gave his name for a certain scheme to assess prostate in histopathology, and he published 2 papers in the same volume of a journal in 1966. And the first is really famous, and the second have been not so valued so far, but the second is decisive, because in the second he and his co-authors describe what they did on assessments of survival rates of patients with this kind of carcinoma. And having analyzed this, he got back to the images or to the slides he has been inspected so far, and he categorized typical patterns of prostate malignancies, and you see it from the original publication in 1966. There was no color pictures in the journals. And you see on the leftmost side, it's still quite differentiated. You see glands, and if you go further to the right, you see it's much more undifferentiated, and that is the aspect which is being considered by the histopathologist. Next slide. He did a scheme or a recommendation how to assess and how to come to these 5 categories. On the right side, you see a sketch from the 70s. This is original work by Gleason, and from this sketch until today, and I think in the last 20 years, the WHO highly recommends to use this scheme. His grading scheme is worldwide in use, and it is used as a score of a sum of the 2 dominant patterns, and this is an important factor for the prognosis on the course of the disease and for the decision of the therapy. The leftmost picture, you see a Gleason grade 3, and this is a 3 because it is known, Gleason recommended to call this 3 because the epithelia have just a single layer and not as in a healthy state 2 layers. And the right is just a mixture, and there's no gland to be seen at all. Next slide. The problems of the grading, even though it's really useful and it's worldwide in use, it strongly depends on subjectivity of the pathologist. And on the right hand side, you see some bar charts, and just symbolizing from a recent paper, you see it at the first glance. There's no really homogeneous opinion, and it is also dependent if the pathologist is trained, and it's really a problem that there are too few reference pathologists having specialized for the disease. And there's also a couple of factors, technical factors concerning staining and so on and so on. Next slide. The scheme recommended by Gleason has been revised in the last, say, 15 years. And that was a result of certain consensus conferences of the worldwide leading specialists on the disease. However, even though the scheme has a bit changed, the main problem of the subjectivity is still persistent. And next slide. And even though they changed the scheme from Gleason score to grade groups, it is just a manual inspection result. And what you see is here a kind of famous Kaplan-Meier curves. And you see the survival is much longer in the mild groups 1, and it's much shorter in the aggressive group 5. And that would mean that these grade groups or Gleason-related assessment is fine and is good. But if you look at the specific patient level, there is much over diagnosis and also underdiagnosis, and that is still the problem. Next slide. So the question is what machine learning can do, and I want to introduce briefly the basics, and we'll show you an example from 2 years ago introduced by the Google AI healthcare group. First, this is Yann Lequin, 25 years ago. He is the main author of AI or neural network scheme called convolutional neural networks. And the sketch on the left-hand side is original from his work on his publication, his famous publication with 16,000 citations. And he introduced his LeNet 5. That is, it took him quite a while to make decisive progress in his network architecture. It is his 5th solution, so to speak. It is a 7-layer network, and he was using it for written character recognition. And on the left-hand side, on the right-hand side, you see 2 more sketches, but it's identical. It's the same architecture, but it's quite recent from NVIDIA or from a data science blog. It's one and the same network, and they all refer to the original work. And there's an example for a traffic sign, and there's another example for handwritten characters. And this kind of network has been much improved or much more developed in the recent years. But I wanted to show you the basics. Next slide. This is the Google work I mentioned a minute before. They were also aware of the problem of prostatic cancer malignancy grading. And they introduced a long paper in Nature Digital Medicine journal in 2019. And they have set up a more or less a classical deep learning system. Deep learning means here there's in parentheses, I'm sorry, it's an unbounded number of hidden layers. So it's not really unbounded, but it's a large number of hidden layers in a network of bounded sites. This is the sense of deep learning system here in general, and Nagpal and others recommended a 2-stage system. In the first stage, on the left-hand side, you see the sketch showing one of these prostate sections. It's not a biopsy; it's a prostatectomy case. And on the right-hand side, you see a corresponding map of the image with some color codes inside. And in between, there's a deep learning system, a large convolutional network. It's no LeNet 5. It's a Google Inception version 3 network. And what they provide here is a supervised learning scheme with some local grades. The yellows are the more severe, and the green is the medium severe, and the gray is there's no malignancy. And once they achieved this, they continued with the stage 2. And they converted these maps in these single specimen-related assessments with a certain grade or grade group, and they did it with a principal component analysis mechanism. Next slide. I get back to the first stage. On the upper row or upper row, you see certain assessments. On the right-hand side, you see the result of the deep learning system, and in between the depiction of the real image, real slide image, you see 3 more maps manually depicted by 3 trained reference pathologists, and that was one of the problems of Google. They only had 3 real experts, but they had 30 apprentices in pathology actually, and they did assessments, and they are not the same as you see. They differ. And below you see all cases of agreement and the discordance, and in the next row you see in these violin charts, you see how the deep learning system answered, and it is quite good in concordance with the pathologists. So the deep learning system also was a bit in doubt when the pathologists were not fully agreeing, as you see. In the middle, for example, if all say 4, that's a yellow dot. Below you see the yellow violin as the deep learning system also answered. It should be Gleason pattern 4. And in the lower row you see just examples of real tissue patches from Gleason pattern 3 to 5 to the right hand side, and intermediate stations. And the more you get to the right, the poorer the differentiation is. Next slide. And that's my last slide for the moment. Afterwards, Markus will continue. I summarize intermediately with Google's papers, confusion matrices. The left one you see is a comparison with of the deep learning system with the experts. And as you see at the main diagonal, quite a high values can be seen. For example, for Google, for Gleason grade group 1, it's a 90% concordance, and so on and so on. And that overall results in some 70% accuracy of the deep learning system compared to the reference pathologists. And the other confusion matrices have nothing to do with the deep learning system, but show how these pathologists under education, under training, assesses. And what you see is they are in tendency weaker in their assessment than the deep learning system, and that is what Google was telling the reader. Our system is better than an average or an average pathologist or a pathologist in training. And just for one case, for Gleason grade 3, the deep learning system was weaker than the untrained pathologists. And what does it mean? It means there's still work to do, and that was the point when we decided to also work on this topic. And Markus will continue now.
Thank you. I will just go to the next slide. So thank you for giving us an introduction on the problem and supplies a little background information. I want to proceed now with 2 examples of our own work in order to show that data science is not just, data science in medicine is not just limited to giants like Google. So the following 2 examples were mainly created.
Rzeczy. Tu mamy 2 przykłady z mojego doktoratu. Zatem tu jest pierwsze pytanie, które żeśmy sobie postawili. Jak możemy tutaj naśladować ten system, który już został w patologii dość dobrze użyty.
And for that purpose, we started analyzing tissue microarrays. Those are a set of tissue samples that have been taken from biopsies and digitalized afterwards. And each sample looks like in the right image. So for each patient, we had multiple cuts, of which 2 showed the tumor area and 1 showed benign tissue. And in total, we used 303 cases that have been supplied by the University Hospital Bonn. For using histopathological images in this context, there are a few problems that need to be considered, and that are the large size of the images, the stain fluctuations, missing tumor localization, and the relatively small dataset size that is inherently coupled to this domain. And to address these problems, from each image, the background was excluded. Then we created smaller patches using a 5x5 grid And for each patch, we applied multiple augmentations that simulate variations due to, for example, technical aspects or treating the cutting procedure itself. So that way, each team got prepared for processing, and the dataset size was also increased. While we were doing this, we realized that there is a crucial role of the stain of those images that can vary significantly, and this can easily lead to confuse a neural network or to lead this neural network for overfitting. So we used a color deconvolution-based normalization procedure that maps reference images stain conditions to another image. So if you look to the image in the left, then you can see we are taking an input image and some fixed reference, and we apply the stain normalization procedure, and afterwards the input image stain looks very similar to the reference one. So using this stain normalization, histopathology images can get more comparable among multiple laboratories or hospitals. So that leads me to our first experiment. Using the pre-processed image patches, we trained a neural network to predict the primary Gleason pattern. And there's no further information about if a patch shows either the primary or the secondary pattern was available. We selected the primary one as an endpoint, as this should be the case for most of the patches at least. In our first approach, we used the already pre-trained network taken from a related work of Avaniti et al., which are a Zurich computational pathology group. And using this pre-trained network with no further training to our data, we achieved an accuracy of a little bit less than 50%. Looking at the figure on the right, we can see that the network slightly tends to predict anything as Gleason pattern 4, and that benign tissue seems to be the second most accurate guess, and that also the network seems to be performing very poor on Gleason pattern 5. It should be noted that the pre-trained network achieved an accuracy of 70% when used on the original data of Avaniti et al., which initially brought us to the question if staining issues may cause the network to fail. And we had an experiment on that one too. And we found out that if we take exactly 4 reference patches that are according to an image of benign, an image of Gleason pattern 3, an image of Gleason pattern 4, and Gleason pattern 5, and normalize all of our patches according to these 4 references, then the network will really just memorize the stain and lead to a result which looks very over-optimistic, like here, with more than 95% accuracy. But if you look, for example, at the row with the 2, which is Gleason pattern 4, we see this is 100% accurate on test set, and this is not very realistic. We tried this trained network then again to other data, and it performed very, very poor. So we realized that we need to do another normalization, and we created a pool of possible reference images from which we sampled. And using this pool and training again on this pre-trained network, we got an accuracy of about 68%, which is close to the one of Avaniti et al., and gives a way more realistic result. And we can see in this image that the main problems arise in neighboring grades, and especially between Gleason pattern 3 and 4, which is not surprising because this is also a challenging task for trained pathologists with a lot of experience. So from this first experiment, we learned that there are inherent challenges in this domain if you want to apply artificial intelligence, which are the stain fluctuations that can change very much among different hospitals, but can really trick your neural network into giving wrong results or giving poorly generalized results. Then another thing is the improper understanding of the internal mechanisms of this neural network. So sometimes the performance seems very good, but we didn't have any idea, okay, why did this work and why did another approach not work so good? Because the data seemed very comparable to us. Another problem is the low amount of annotated data, which cannot really be compensated because due to time constraints in clinical practice, if you imagine deep learning systems require very, very big data set sizes, and you cannot take a pathologist to do a grading for like 100,000 slides. That's way too much. And this very likely results in overfitting effects which make the network be poorly generalized. And this is exactly the effect that we observed when we took a network that was trained on other data, and then it kind of collapsed by 20% accuracy on our data. So we formulated our question a little bit different and asked ourselves, how can we use the advantages of neural networks without relying all too much on annotated data in the first place? And for our second approach, the procedure was a little bit different than the standard one. So we did a segmentation of clans. Afterwards, we did a reference-free stain normalization. And with those created image patches, we did an unsupervised feature extraction and a detailed feature analysis. For this experiment, we took other data than in the first one. We took 500 cases from the Cancer Genome Atlas, which are not TMAs, but whole slide images, so separates taken from radical resections. And you can see the general pre-processing procedure in the image here on the left. So first of all, tissue types are detected using the clustering approach and used to create segmentation masks that mainly consist of nuclei in cytoplasm. And that way, glands can be detected, as can be seen in the last step. And I want to elaborate a little bit more on this clustering step, which happens in the first stage. So what we are basically doing is we are converting each whole slide image, which you can see here as an example, to the LAB color space, and then we apply a so-called Gaussian mixture model. And luckily, using those clusters that this Gaussian mixture model forms, as in the upper right part, we can assign those clusters to stroma, cytoplasm, nuclei, lumen, and mucin. And that way we know where in the image are nuclei and cytoplasm. And by building compounds of them, we can detect glands and extract image patches that really show a gland and really show regions that are of interest for us. Using this procedure, we can also normalize the stain of each image without needing a reference. So it's always a closed system for each slide itself. And yeah, we created around 100,000 image patches using this procedure. And with these image patches, we applied another model, which you can see here. It's also a neural network approach, but this is a special kind of a neural network called autoencoder, which does not rely on any labels, which are, in our case, the pathologist's ratings. So we can do this feature analysis with neural networks, but we do not need annotations, and thus we can take way more data than we could in another case. So what this thing does is it converts an image to a lower dimensional vector that we can use for later analysis and to improve labels, for example, which you see in the lower part of the image, but I won't go too much into detail now. And using this transformed vectors out of these images, which we call embeddings, we first of all did a qualitative analysis that you can see here, and we checked if the embeddings that are calculated by our neural network match with the Gleason patterns, or with the Gleason patterns, as we already know that those cover most of the morphological groups that we want to detect. And we saw that there is already groups formed, so you see that the colors here align. But we also saw that there is a strong overlap, so it's pretty hard to tell apart if this, what I called Gleason 5-5, which is equal to Gleason score 10, so 5 plus 5, if it is Gleason 5-5, or if it is, for example, Gleason 4-3. And to further reduce this overlap a little bit, we did another thing. We did filtering on this data using another machine learning approaches. And to be more precise, what we did is we removed embeddings of patches showing benign or low relevance tissue and repeated this qualitative analysis for non-mixed Gleason scores 6, 8, and 10. And what you can see here is that we found out that there are certain clusters of similar vectors are formed, and that we can use our network to tell apart which if an image shows a Gleason pattern 3 or 4 or 5. And the nice thing about this is that we can take a very large group of patients and analyze patterns that are detected in there in parallel, which would be hard to do manually if you would do it with a pathologist on a direct image. And this was also pretty impressive. What we also did was selecting a few images out of these latent space and checked if they really align with patterns. So I have to say we have no explicit medical background, so we couldn't do the analysis really in detail if it's medical correct, but we checked for a little plausibility. So now I'm running a little out of time, so I will speed a little bit up. And the second approach that we did is we used these clusters and this continuous order of if a pattern is Gleason pattern 3 or 4 or 5 to improve the labels that we already had. And then we trained a neural network with the original labels that the pathologist set and landed at an accuracy of about 68%. And afterwards, we tried to clean up those. So to look, okay, if a patch is got the Gleason pattern 4, but it lies between 3 and 4, but more in the direction of Gleason pattern 3, then we will re-evaluate it with Gleason pattern 3. And using this approach, we got an accuracy of 74%, which was an improvement. And we could even observe that when we are not just looking at patch level, but for the whole slide, so for the whole patient, we also had a slight improvement while both networks were performing very low because we had not so much data. Yeah, we also validated that on checking what the network actually sees within this slide. So what we've learned here is that in general, neural networks are very, very well suited for mimicking this Gleason grading system, and especially for analyzing data and large cohort of patients' data. There's, however, a lot of things that are still to do. For example, the uncertainty if a patch really contains a tumor, or example given hyperplasia or benign tissue, is really difficult to tell apart. We have very small data set sizes, so we need new network architectures that can handle this better. We need to break up the black box principle in AI even more than we already did with our second approach. And the most important thing, prospective studies have to be done because there is no work currently that has ever used such a system in a prospective study. So I want to acknowledge a few colleagues of the Fraunhofer Institute again, and Glenn Christiansen of the University Hospital Bonn that supplied us with the data and helped us with our work, as well as Martin Marens and Christian Meissner of Webfleet Solutions for their support, and the Cancer Genome Atlas project, which is the base of our data. Thank you.